before we begin. A couple of quick housekeeping items before we begin. Please note that this meeting is being recorded and the recording will be archived on the Cardiogenic Shock Registry's website. Also, please remain on mute unless you're asking a question. Questions should be held until the designated times. We do recommend that you submit your questions in the chat to be answered during the Q&A. Also, the recommendations and opinions presented by our guest speakers may not represent the official position of the American Heart Association. The materials are here for educational purposes only and do not constitute an endorsement or instruction by the American Heart Association or American Stroke Association. The AHA or ASA does not endorse any product or device. Now I'm going to hand it off to Dr. Morrow. Dr. Morrow is a critical care cardiologist at Brigham and Women's Hospital and also co-chair of the steering committee for the American Heart Association's Cardiogenic Shock Registry Initiative. I'll pass it over to Dr. Morrow so that he can overview what you can expect today.
Thanks very much, Meryl, and thank you all for joining today. We're very excited about this grand round session. It's on a topic that is of deep interest to all of us who practice in cardiovascular ICUs and how we can best coordinate the care of our patients with cardiogenic shock. And I'd say we will hear from our experts in just a few minutes that I think there's not a one-size-fits-all solution. And so we'll use this hour to try and help everyone in the audience think about how to best construct your shock teams in your clinical practice environment. And so we'll have first a introductory state-of-the-art talk by Dr. Thomas Hamp, who's director of both the cardiovascular ICU and the temporary mechanical circulatory support system at University of Utah. And then we have a terrific panel that will talk through some of the issues and give you some ideas about how they've tackled shock teams at each of their individual centers, and we'll welcome audience interaction and questions from all of you at that point. So at this point, I'd love to hand over to Dr. Hamp.
Thank you, Dave. It's really a pleasure to be here. And I think the most exciting thing for me today is just to see all of the interest in cardiogenic shock teams that the AHA has generated with this talk and the excellent turnout. So I'll be talking about cardiogenic shock teams. And I think the main goals I have today before we get to the panel discussion, I want to summarize what's been happening in the United States, a little bit of the history and a lot more of what the current practice is around cardiogenic shock teams. And then I want to talk about why shock teams might work and some of the cost effectiveness that predict the individual patient success and how we can apply the shock team and how a program can be successful. So we'll take a little trip down memory lane, and this seems, by my accounting, like it was just yesterday, but this is now 15 years ago. The very first publication that I can find in the literature about a shock team came from the Mayo, Arizona group, and it really was a traveling shock team concept where they were sending a team out to sites where their patient was unstable, making some decisions at the site, and then managing them and getting them back from the to the hub hospital. And the team then consisted largely of a cardiac surgeon and a heart failure cardiologist, a perfusionist, and an ICU nurse. This is a team that had to be pretty sparse to travel. They'd go to the hospital. They wouldn't initially do anything other than stabilize the patient and then make a game time decision on whether a patient needed MCS. And this is just a pilot study of 27 patients. And it turns out when they did this, about half the patients were placed on VA ECMO, and they had a very high survival to transfer. Now, noting that because this is going to a site, putting a patient on ECMO and deciding to come back, this program has a little bit of selection bias, but they got 25 out of 27 that survived to transfer, and half of those patients survived to discharge from a really acutely ill group. Fast forwarding now to the modern shock team, which evolved out of this early practice. There's a core team of, I'd say, 4 types of physicians that most shock teams will employ: an advanced heart failure cardiologist, a cardiac surgeon, an interventional cardiologist, and an intensivist. And then we'll hear in the panel how everybody's shock teams at their various sites is set up, but additional members that might be included in the shock team are a critical care nurse, a perfusionist, a respiratory therapist, and I'll add to that as well a flight team nurse, which might be a distinct type of critical care nurse. So what does a shock team actually do? There's a couple key moments in time. There's the intake conversation that a lot of resources go around, making this a 24/7 call line, either in a hospital or within a system or region. And that's focused on these early management decisions, and we'll get to why that's so important. And some key therapeutic options that have to be decided in as quick a time as possible. That's the role for temporary mechanical circulatory support, or TMCS, the role for early revascularization, and then anything else that might, those are the two heavy hitters, but anything else that might be acutely needed, say a valve procedure or something else for an arrhythmia that might be necessary. And then there's a resource triage. And I put the example of Sky Stage here because we've actually recently deployed this at our university to make a decision about what level of flight nurse needs to go out to a site, depending on the Sky Stage of the patient that we're taking in. If it's a Sky C patient, somebody who's a little bit more junior in the nursing career can go with the flight team. A Sky D or E patient, we need the more experienced nurses that are going to be able to manage the patient in flight as they're coming into our hospital. After that initial conversation, there can be a role for daily or more rounding as a consultative team. So it moves from an intake conversation to a consultative team. And that can really talk about the day-to-day management of a patient in shock. You can have hemodynamic rounds, whether a therapy needs to be escalating. You chose an initial therapy, it may be vasoactives or a type of temporary MCS, and it's not working. Oh, looks like I got muted there for a second. We can go just back a slide. And whether temp MCS it needs to be managed, the escalation and de-escalation of a therapy, and then ultimately the trajectory of the patient can evolve over time as we get to know these patients and get to know their physiology, whether they're going to need to have an LVAD or transplant as an exit strategy, or if they can recover, or if we don't think any of these are an option. And then, of course, preventing and managing the complications that can come about with temporary MCS or just critical illness of limb ischemia, bleeding, and all these types of things. Next slide. So I put three essential checkpoints that I think every shock team has to consider. The first, right away, do we need invasive hemodynamic monitoring? And I'll show some evidence for or against this in the coming slides. Second, and this goes back 20 years, one of our earliest decisions we've known about in shock is whether an unstable patient who needs revascularization needs some other sort of mechanism to stabilize them through a procedure, and whether they need that revascularization up front or whether we have to wait because the patient can't get through it. And then lastly, whether we need early mechanical circulatory support. So I'm going to say a couple slides here, and the gist of this is time matters for all of the decisions we're making in shock, and that's why a shock team, I believe, is a critical piece of the care we provide to Cardiogenic shock. And time matters going back to Judy Hockman's trial in 1999, looking at the role for early revascularization in shock in a STEMI patient. And even though the 30-day mortality, the famous story was a trend towards improved survival, but didn't meet statistical significance at 6 months, and then thereafter, there was a 13% reduction in mortality from the use of early revascularization versus delayed. So time matters when it comes to revascularization. Time matters when it comes to can we stabilize a patient and offer whatever resources we need, both in a 24-hour window and more recent data, even in a 6-hour window. If you look at the survival of a patient to the end of the hospital stay, where they came in and whether in those first 24 hours a patient improved, unchanged, or worsened, across the board, it's less so the Sky Stage they came in at, and even more of a matter how they evolve in those first 24 hours. If you take a Sky D patient, for example, and they improve, they have a much better survival than somebody who's even unchanged. So we have to be able to move the needle, and so that requires early intervention, and data can show this at the 6-hour mark as well. Why does time matter? I don't think I've ever given a talk without this slide that Reynolds and Hockman had published back in Circulation. It's because we know that cardiogenic shock is not just a hemodynamic problem anymore. It is a hemodynamic problem at the start. Nobody would deny that it starts with a cardiac problem and you underperfuse the tissues because of a drop in cardiac output from an acute myocardial infarction or from heart failure cardiogenic shock that decompensates or is de novo. But what happens as the body sits there in an underperfused state is it kicks off the systemic pathophysiology where temporary mechanical support or high-level vasoactives might still be necessary, but are no longer sufficient to reverse this pathophysiology. What happens is the body underperfuses, we lose compensatory vasoconstriction, there's endothelial dysfunction, microvascular dysfunction, and if we wait too long, just putting a device in or just starting inotropes actually misses the window for that early intervention where you can really move the needle. And that's where all the data are pointing to now in cardiogenic shock. So we have to be timely. And other data from larger scales, looking at the role for transfer. I want to pick this apart a little bit. This comes from the cardiogenic shock working group. And these are patients that had de novo shock at the hub hospital versus patients that were transferred into the hub hospital. And native heart survival was comparable, but why? Because patients were dying less and being offered heart replacement therapy more. So that's important. And the next slide, I think, is really telling. There was a big difference in effect modification, whether these were heart failure patients and AMI patients. So I'll start on the AMI side, actually. There was no difference in native heart survival or mortality or heart replacement therapies. In heart failure patients, that's where all of the difference existed. Patients with heart failure that were transferred in were dying were dying more often, rather, if they were transferred, and being offered heart replacement therapy less often, sorry. Why is this happening? Well, one possible explanation is because we have appropriate systems of care around AMI shock. No matter what hospital you're in, you come in with an AMI, you go right to the cath lab. We have all of the tools available and all of the folks interested in timeliness and durable balloon time at that hospital. And transfers don't take nearly as long. We can do cath lab to cath lab transfers. Heart failure patients are left sitting there under-recognized and under-treated to a larger degree before they reach a maximal level of care. And that leads, I think, in large part to the mortality and the heart replacement therapy differences here, even though the native heart survival is the same. You'd rather have a transplant than the death outcome here. So I want to go through the data for shock teams, and I'll start with, we have a little bit of pride in publishing one of the first modern shock team examples at the University of Utah. And this is really a simple model because we hadn't had all the data yet, and I'll show you what we've updated to. The biggest thing here is we just activated all the people all at once. I think that was the secret sauce. We got people talking about shock instead of sitting in silos making a decision unto ourselves. We know the role from other teams, from STEMI teams, from PERT teams, from trauma teams. We know that having a multidisciplinary discussion when we make heart transplant or valve decisions is important, and we can do this in real time in that timely fashion. So we got the heart failure cardiologist, the surgeon, the interventional cardiologist, and the intensivist, who's our CVICU attending physician, all on the same phone line. And if it's a STEMI, we had to go to the cath lab. We consider early temp MCS if they had a set of criteria that I'll show you, and we push for right heart caths early. In the non-STEMI, we push for right heart caths early. We had a similar set of temporary MCS criteria. And then maybe or maybe not, they'd need a left heart cath. Even if they weren't a STEMI, they might be an NSTEMI or an unstable angina, and we might need to look at revascularization early. Next slide. What was our protocol? Well, we were using Impella via ECMO, balloon pump, if a patient was hypotensive or needed IV inotropes. These are the same shock criteria we've had since the IABP Shock 2 trial and other more recent trials. And they had to have evidence that this wasn't just a under-resuscitated hypovolemic patient. They had an elevated wedge pressure and their cardiac index was low. And then they had or some pulmonary edema or impaired end organ dysfunction if we didn't yet have the right heart cath to show us these things. And when that happened, next slide. The aim was to implement the shock team and then study what happened before and after. Of course, this is not a randomized controlled trial. There could be era effects, but we had 121 patients that we managed shock before 2015 when we rolled this out. We had 123 patients in the 2015 to 2018 era that we analyzed this, all of whom had been managed with temporary MCS. So these are all acutely ill patients, and we looked at the 30-day all-cause mortality. Next slide. So there was a big survival difference where we had 133 survivors overall, 99 were weaned from TEMP-MCS and 34 were bridged to LVAD. But the control cohort, all of whom were managed with TEMP-MCS, had a lower survival probability at 30 days that was statistically significant. But single center and just the University of Utah. So next slide. Inova did the same thing around the same period in time, and they showed that in AMI or decompensated heart failure patients, their pre to post survival went up. The AMI had the biggest effect. Look at this, from 44% survival up to 82% survival. There was an effect, though, in the non-AMI patients as well, from 60% up to 72%. But again, all of these were single center. Can this be replicated at a wider center? We still needed to know this. Next slide. Several of the investigators that are on this call published this multi-center trial out of the triple CTN looking at the management and outcomes of cardiac shock teams across the board. I think there's a lot to learn from this study. Next slide. These are the three big take-homes that I get from this, and I love when we get to the panel to hear other folks' thoughts on this. But PA catheter use went up when there was a shock team deployed. Overall MCS use, temporary MCS use, went down. That's very interesting. But when it was used, it tended to be more advanced MCS, which I'll define in a second. And when you put these two together and just looking overall at all the different things, I think these are the two of the pieces of the magic sauce, although we can't define everything because this is a bundle of care. The CICU mortality went down with cardiac shock when managed with the shock team versus no shock team. Next slide. Do PA catheters help in cardiac shock? Well, we know they don't help in a chronic heart failure patient, and we've known this since the ESCAPE trial, but that's not who we're talking about when we're talking about shock and cardiac shock with, now we've got SCAI stage terminology to define this. This is not the SCAI A or B patient who are in shock but chronic heart failure. We have sicker patients that we can now recognize in a timely fashion. Next slide. And when we use invasive hemodynamics, complete profiling in SCAI D or SCAI E patients in particular, overall there's an improvement in survival. And in the sicker patients, we really need these as far as the observational data go. Otherwise, we're flying blind. We can't have the finesse in hemodynamic management without invasive hemodynamics to make all the decisions in a timely fashion that we need. Of course, this is not a randomized trial, so folks are interested in doing this in a randomized trial under the PAX trial that's ongoing, and so we're eager to await these results. But for right now, many centers have adopted a practice of using PA catheters more and more because of the observational data and just our discomfort with managing cardiac shock without a PA catheter. Advanced MCS, I think, is an important topic, and this data all predated the dangerous shock trial. But what happened is when you got the shock team together and we discussed what level of support was needed, we tended to stay a little bit more away from intra-aortic balloon pumps, where the data are murkier. We have IVP shock 2 and AMI shock showing no benefit, and we now have other more recent trials looking at heart failure shock that show this, but we didn't have this at the time. But we tended to use less balloon pump and more Impella, and a comparable amount, although a little bit more statistically significant, of tandem heart, and ECMO was, again, comparable, and temporary surgical LVADs were comparable. But I think the biggest difference by effect size was more Impella and less balloon pump use. Next slide. And this is sort of validated by Danger Shock, which followed this, and we didn't have these data yet, showing that in the right patient at the right time with the right device, temporary MCS with use of Impella, this was the CP, could improve 30-day and 180-day survival compared to the standard of care, which included perhaps vasoactive medications or other sorts of non-protocolized temporary support. Next slide. This doesn't get away from one of the reasons why I think we need still expert opinion at the level of cardiac shock teams is we still don't exactly know who the right patient, the right device is. So Holger Thiele came out with this study, a meta-analysis, just reminding us that all of the trials before, we still haven't totally shown the benefit of temporary MCS and the exact combination of therapy and time that's going to work for this population. And so we still need to have folks experience guide this until we have better data. Next slide. We've taken this and we've synthesized a newer version of the Utah cardiac shock team protocol that I'll share with you now. And this is continuously evolving. We don't treat this like a static measure. I think one of the roles that I take on in helping to direct this is that we try to follow the literature, and the literature to us is now pointing to an earlier use of temporary MCS where we have equipoise, and we look forward to some of the upcoming trials of use of this, like the Integrate trial that will be looking more in a SCI-C population. But we have equipoise in that group, so we adjudicate which temporary MCS or other therapies we need based on the SCI stage, what nurses we need to fly out on a flight team, what physicians need to be involved, what resources we need to apply, and what therapies are needed based on SCI stage up front. We typically will use invasive right heart cath or leave-in PA catheter monitoring, and based on the LV, RV, or BIV anatomy of a patient, decide what level of support. We put here IABP or Impella. I will say, practically speaking, we have a larger share post-danger of the use of Impella for LV only, or even biventricular dysfunction, where we think we can unload the entire system if they're a lower level SCI stage, SCI-C or SCI-D. As they get sicker, we're tending to use biventricular support like a Bipella or a Impella or a Protect Duo strategy or VA ECMO. And all of this is informed by what we think is going to be the end stage exit strategy for the patient. Next slide. I want to spend a few minutes because a lot of folks are interested in whether they should launch their own cardiac shock program if they don't have one already. And cost effectiveness is a big conversation here. Next slide. So we looked at this at the University of Utah, and it does turn out that shock teams cost more. And this includes everything from ICU charges to device charges, to operating room charges, floor charges, and organ transplant. I'd say one of the bigger shares is simply the amount of resources spent in the ICU when we're using temporary support. It requires more one-to-one nursing level of care. And in a patient who's living and doesn't die from cardiac shock, they may actually have an extended length of stay. But is that a good thing or a bad thing? If they're surviving, that's a good thing. But when we look at that and adjust to get the quality adjusted life years, it turns out that 102,000 is the break point where we're getting $102,000 spent per quality adjusted life year. And when you look at the cost effectiveness literature, I think early studies in this coming from the dialysis world and sort of, these are normative cutoffs that we create as a society. The accepted cutoff for a quality adjusted life year is around $150,000. I'm sure that must go up with inflation every year, but when we studied this, it was 150,000. And so this is actually 2/3 of that. So cost of at our center, which is a quaternary care center, it is extremely cost effective to have a cardiac shock team. Next slide. But there are challenges, and everybody should be well aware of these challenges. And when we get to the panel discussion, we're going to talk through some of these. We have to be able to provide that timely response system, and that requires consistent staffing, reproducible 24/7. Shock can come in at 2 a.m. on a Saturday morning, just like it can come in at 8 a.m. on a Thursday morning. So it has to be 24/7 to really get the maximal benefit. You have to define, based on your existing infrastructure, how you think you can navigate to what we think is the optimal organizational structure. And I shared with you what I think are the core components and the potential add-on staffing from the physicians and the nursing and all the other levels of care. You have to have a way to communicate effectively. We'll talk through in the panel discussion what each center is doing around this. And how do we make sure this is equitable and that workload is able to be reimbursed? These are challenges that you have to navigate because some of these things are consultative, but maybe separated from the actual consultative fees you can generate themselves. Physicians historically love autonomy, and this is making a team decision. But I think a lot of us have become more and more comfortable that the outcomes are so much better across the board when we make these multidisciplinary heart team decisions or now cardiac shock team decisions that we're comfortable navigating this. But you have to be at your own center as well, and you need administration buy-in. And I think as a result of this, it's probably the case if we had a cost effectiveness study, which we should generate at hospitals that don't have all these resources already in place, that not all hospitals can or should operate cardiac shock teams to the full extent. Maybe there's components of them that they can operate, and we can pick apart what's necessary and what's feasible at each site. Next slide. And one way to conceptualize this is that there could be circles of cardiac shock care. Now, every patient and every system, and system could be loosely defined to a region or a geography or a healthcare system, should have the ability to navigate to all levels of care depending what they need, but not each individual hospital needs to have access to every therapy possible. And the most important thing across every center is the ability to recognize shock, provide early resuscitation, and then get patients to where they need to be based on an initial triage that has to happen for every patient. Next slide. And one way that we published on last year is to conceptualize 3 tiers of hospitals. And I like this framework, but I'm open to hearing the panel's thoughts on this as well. That smaller community hospitals or centers are maybe able to manage a patient with SCI B or C in those early hours and make sure that they stay SCI B or C or improve, remembering that 24-hour data from multi-center studies that we have to see improvement, or you need to be thinking about transferring a patient out to a higher level of care. You're going to need to have a wide range of physicians there, cardiologists, emergency physicians, but you may not have to have temporary MCS, but you need to have at least vasoactive medications and the ability to get in touch with higher levels of care as needed if a patient's not doing well, deteriorating, or we think up front they need that level of care. A tier 2 hospital takes everything a tier 3 has and then can offer temporary support with a balloon pump or a PVAD. Maybe not all elements, particularly the right-sided devices, tend to be a little fewer far between with less experience. And so maybe you aren't offering a Protect Duo or via ECMO, but you can offer temporary MCS to manage a higher SCI level patient, C or D. And then a tier 1 hospital has to be able to offer all of the advanced MCS options to support LV, RV, biventricular dysfunction with ECMO, and then have the exit strategies to get these patients where they need to go with transplant or durable LVAD. And they need to be a referral hub for the region for this. And it may not be the case that a patient has to go from a tier 3 to a 2 to a 1. Patients may be so sick that they have to jump right from a 3 to a 1. And I think the biggest single word I can apply to all of these when it comes to a hospital system is communication. It doesn't matter what resources exist at whatever hospitals can purchase and afford and is cost effective. They have to have access to communication to these higher levels of care to get patients triaged and moved if necessary. Next slide. And so our current system strengths, we have rapid triage. I think a lot of centers need to think about whether that's the case, but most centers do. And we have multidisciplinary decisions on selection and timing of temporary MCS. But a challenge is across the country now, we've got heterogeneity in the composition of shock teams. And like I mentioned, unclear cost effectiveness. We've shown it at our system in a single center in a quaternary care center, but what's the cost effectiveness across all hospitals? What's the essential or bare minimum? And we need prospective data that we don't currently have. As we think about the future and how to standardize this, we can develop and institutionalize these tiers that we suggested in the previous slide and paper and codify best practices. I think even across our panel, as we get to it, you'll see that we have differences in how we approach shock team. And I think we need to expand access and find ways to incentivize expanded access across hospital systems and work with insurance companies for this. Next slide. And I'll wrap up sort of by saying that we need data to do this. We need to have prospective data, and there's been a call to action to promote this in a way that some of our registries haven't been able to access the shock team component as robustly. So some of the folks on this call today are thinking through how to actually study this and create a registry around the shock team itself. Next slide. So that's everything I have today, but I'm very excited for the panel now, and so I'll kick it over to Dave to launch this.
Yeah, thanks so much, Tom. That really was terrific. I mean, the history in Utah is amazing to see how it's played out, and you really set the stage just perfectly for this panel discussion because you raise so many of the topics that we need to grapple with as a group. And I think bringing together this outstanding panel will really give us a chance to for the audience to hear slightly different permutations of how people have set it up with their system. And so you can see we're joined by a fantastic group, Connor O'Brien from UCSF, Kieran Sidhu from Penn, and Esther Vorovich from Northwestern to cover different parts of the country as well and get geographic input. And maybe I'll kick off by just us going around the panel and talking a little bit about how you've set up the shock team at your hospital. In particular, maybe we'll just focus on who's on the team and how do you activate them. And then we'll come to a lot of other issues as we go around. Maybe I'll start with Connor, simply since you were first up on our list, and then we'll go from there.
Awesome. Thank you for having me, Thomas. Killer talk, as always. And great that you're putting that data out there. It really helps the rest of us and the rest of the world figure out what to do. So at UCSF, we started off with an activation that included all members, and it was just really cumbersome to get everybody on. And so what we did is we started funneling all of the calls through the cardiac intensivist, the CICU attending. And so initially there was only three of us, and now there's four. And we work in a really closed loop system with the transfer center so that who they run all questions for triage, insurance approval, and everything it can be a really tight, refined number of people that know how to answer questions in real time to make transfers happen quickly. And one of the challenges we ran into very much, like you guys, we couldn't get any support to get everybody protected time across all the needed services. So since we're all dual trained and we understand a decent amount of the procedural requirements, what we do is we then have a small number of people within each group of interventional cardiology, cardiac surgery, structural cardiology, who are sort of more familiar with shock protocols. And we reach out to them individually and get the imaging and everything necessary really quickly. And we have that mostly streamlined into a system. And then we get that data in front of the people who need to see it to understand, yes, no, is this procedurally possible? The truth is we've sort of figured out over time is that we know enough about what we're going to figure out when somebody's not within our walls, just as the person receiving the phone call, that we can pick and choose people who are going to be definitely not candidates for something, and then people who have a shot. And as long as they're within that window of people who are likely going to be viable candidates for either surgical procedure or anything like that, we really do most of the intake to just bring them in and streamline the process. If there are gray zone questions that are really procedural questions, that's when we start bringing in the proceduralists really quickly. But we try to just really streamline getting people on support and transferred as fast as possible without excluding people for like the stuff that's truly outside of our training scope.
Yeah, and Connor, one follow-up question before I move on to Karen. How do you then have a unified discussion by the team once you've decided to accept someone, either
Yeah.
en route or when they're there, or are you still having a multidisciplinary view but through separate conversations?
So what we do is we then get everybody after we've dealt with the acceptance, just because that's the part we want to just get moving, especially if somebody has to be put on ECMO, because we have to get all the resources allocated in a lot of these places in California that are, I mean, a lot of you deal with large catchment areas. We then call everybody who might have to hear about the patient prior to them being in an ambulance, and we let everybody know. And that does funnel through us. We'll do group calls, individual calls, depending, go down to people in the cath lab, whoever's on, and we do a lot of really closed loop communication and data review together. And we can talk more about procedurals. We do a lot of stuff bedside because so that we own a lot of that responsibility rather than having people who are going to have to come in and modify things unless they have to get a coronary angiogram or go straight to the OR. And then we also have a safety check. That's actually been one of the things that we've done. Rather than having a lot of the MD involvement, what we found is the things that bit us mostly for safety issues was when we got bad information and somebody who wasn't at bedside, something had changed, had given us the sign out. We then went to the big group. So what we added is when the person's about to move, we have our MCS coordinators take a technical phone call where they just have a checklist that we built where they have to get the data from either the perfusionist or bedside nurse. And then if something's out of alignment between our two reports, they call us. So it's a completely independent review that we try not to be involved in just so that we get true safety data, mostly to identify bleeding if somebody's on support and then other like vasoplegia issues. So that's another, so it is a layer of safety that we felt that was sort of beyond the normal MD scope where we were getting burned.
Yeah, I must say that that's something we've learned from you, and taken that home because I think so often patients have arrived not exactly as they were billed in the initial conversation. Sometimes that's because things change, and that sort of final check before they come makes a lot of sense. Karen, do you want to describe what's the same and what's different, and what do you guys do at Penn?
Yeah, so many similarities. I think one of the key differences is we have a shock team leader. So Joyce Wald's our shock leader. And so many of the calls come directly to her, or if they come to the transfer center, sort of get funneled to her. And then she's responsible for getting other people on the call. So if it's a valve issue or an EP issue, she'll get the appropriate folks on the call. There's usually an intensivist, a heart failure cardiologist, a surgeon. And then depending on destination, we might also get like a cardiac anesthesia doc involved if they're going to our cardiac surgery ICU. And the point of the call is to sort of understand more about the patient, how sick they are, how soon they need to be transferred, what the appropriate destination is. Do they need to be put on more support before they can be transferred? Like, do they need to be put on ECMO? Do they have the capability to do ECMO? Sometimes we'll actually do mobile ECMO. So our team will go out and put somebody on ECMO and bring them back. And then just sort of vetting the patient in terms of, are they going to be an advanced therapies candidate? Are we bringing somebody over who's not going to be a candidate for anything? And then, that's probably not the best use of resources, and probably not best for the patient either to, come, several hours and then just have care withdrawn or whatever may happen. Yeah, so everybody's on the initial call. There's no sort of secondary calls. So it takes a minute to get all the folks on the call. And then it's about figuring out the appropriate destination. So if they need ECMO or an Impella 5.5, maybe they should go to the cardiac surgery ICU. Sometimes we've had people go direct to the OR even. And then if there's no beds, sometimes we reach out to like our sister hospital, which is Penn Presbyterian, just so we can get people moved quickly and that there aren't delays. Um, Most of our shock calls, and I would say there's probably like 3 or 4 shock calls a day, are for outside transfers. Rarely we'll do shock calls for internal patients. So usually that's like, a congenital patient or a pregnant patient in shock where it's like a little bit over our heads as heart failure cardiologists, and you want to get OB or congenital on the line. And so we'll sometimes do inpatient shock calls, but most of them are people that we're transferring in, and then whoever's on the call will continue to follow the patient while they're at Penn.
Yep, and then I wanted to, I'll interject too that we should talk a little bit about inpatient systems too. We actually do a fair amount of shock team evaluation, even for people who are already with us, to really bring that multidisciplinary view. But I want to go to Esther. I know in particular you all have a very well developed sort of system of care within the broader group of hospitals that are in the Northwestern system, and we'd love to hear about that as well as about the makeup of your shock team.
Well, one, thank you for inviting me, Tom. Awesome talk as always. So we have we have some similarities, some differences from all of these. So one is to start is this is a little bit of a labor of love, both in getting it started and getting it and continuing to do it. And some lessons learned along the way is that you have to be a little nimble and it might have to change. And so the way we have it now is not the way we started. So we started it with trying to go through one person, and then we decided that we're not going to do that. And all of this depends on how well the group, there's all these bigger picture issues of like, how is compensation, how are people getting paid? Right? Because Connor brought up like, getting people protected time to do this. I have not heard of people getting protected time unless you're leading something. How are people getting paid? Does the institution want it? Are there buy-ins from the institution? And, everyone always, we're all humans are incentive-based creatures. So we all have to have some skin in the game of what someone's getting out of it. And so the reason it worked at Northwestern is those things kind of fell in place. One, we are a bit Midwestern. We get along well and we're nice and kind of everyone seems to get along, at least and is polite to each other for the most part, right? So the leadership wanted this. So that's step one that's important, right? Because if the head honchos want this, then people, when they get annoyed about A, B, and C, because they always will about something, that you have some leverage there. And then two, I think the other thing I learned is you need to have like, I hate this word because it's like a very administrative heavy word, but like in champion in each group, right? You have to have someone from interventional. You have to, and we don't have fully staffed critical care cardiologists, right? So you need to have an interventionalist, a heart failure doc, or whatever, a person from each of the groups that you have on has buy-in so that they can help also calm some of the stress that comes out in their individual group. And so who we have on the call is heart failure, interventional cardiology, cardiac surgery, ECMO perfusionists, CT ICU, which is our surgical ICU, charge nurse, our CCU, which is our medical cardiac ICU, charge nurse, and ECMO perfusionist comes on. And then sometimes we have pulmonary and sometimes we have critical care come on. The way it happens is, so at our, we're a 12 hospital system. And so we have a big code aorta program, for example. So anyone who wants to call, like at any hospital within our system or another system having an aortic dissection, there's an emergency line. Same with a neurosurgery. Hey, we have an acute brain bleed. There's a line. So ours is, we call it the 5-5s. It's like 695-5555. You call and you get an operator who is obviously not medically trained, and you're asking what team you want. And we created a workflow of 3 questions to ask. And then they call that 555 number that's not at all in the cardiology world. And then if they get directed to the shock team versus the lung rescue team, it then gets paged out to whoever's on call for the team. There's a virtual pager that gets signed out by administrators. You like never depend on attendings to sign in and out pagers. Right. So, and then everyone gets paged, everyone takes call, and then they join the call. There's a lot of like bumps along the road. At one point we had like the CCU attending and the interventionalist. And then so we ended up having 2 interventional cardiologists on the call. They didn't like that for obvious reasons. So we changed that. But everyone does call in, and they call in for every call that we start. And yes, it takes a minute or 2 for some stragglers. And then we wait on the call and we have the primary team then present. And we have actually tried to change our culture. So we do about 50-50 internal versus external. Actually, one of the biggest callers is heart failure, right? So as a heart failure doc, I make the analogy, for most of us, we're like general contractors. We never actually get our hands dirty, but we have to organize a bunch of people, right? And so I used to feel also the other analogies like
that's Connor's job too, we know.
Yeah. And like the kid of divorced parents, right? I'd call interventional and they'd be like, they don't need whatever, they need ECMO. And surgeons would be like, they don't need ECMO, they need a balloon pump. And you're like calling back and forth. And so instead you get mom and dad on the line right away. Everyone has a conversation. It's very actually educational. So they actually talk through access issues. And let's say we plan for ECMO, the interventionalist actually will pipe in with some ideas, right? Sometimes it's go to the cath lab. We're going to do A as a step 1. Let's try a balloon pump propeller. Let's reassess in 30 minutes and see if they need ECMO. Or we'll often place 5 French sheets as placeholders in the cath lab to then be able to upgrade to ECMO. But everyone's on the call. We discuss, do we need venting? We have discussions of, do we 100% think they're not an advanced therapy candidate, because that might pivot. And we actually get a wide range of phone calls. And so not everyone is always quote unquote useful. Like sometimes we have a lot of very PCI heavy questions and I'm on the call and I'm not adding a whole lot other than I try to do some of the scut work because I know I'm not doing actually the dirty work, right? So, so you're on there to kind of be part of the team. I actually think it helps build relationships quite well. I think it helps make people, it brings people together. I think a lot of times this phone call gets called internally when we don't think there's anything left to do, but one individual doesn't want to make that decision on their own. And I think from a team wellness perspective, I actually think it brings some peace that like, hey, I've actually explored all these options. And I think it also helps with talking with families. And so we've tried to change the culture of this is just a transfer line where we're transferring patients in. This is a consultative line, both internally and externally. And the consultation externally is like, hey, do you need help managing? Because you don't have, let's say, heart failure. And do you need and do we think it's appropriate for transfer? Because I'm sure all of you have bed shortages.
Esther, I have to say, I think you just perfectly encapsulated really what I think is the secret sauce of shock teams, Riley. It is that that multidisciplinary conversation. And out of that, as Tom showed, I think we make some decisions about evasive monitoring, we make decisions about mechanical circulatory support. But given the limited impact that those things may have, at least in the evidence base, I think it's the conversation and bringing everyone together. I think it's just a perfect illustration. I want to ask one quick follow-up question, then I want to go just around the group again to just very quickly talk about actual activation, just kind of get practical for people. And then I want to make sure we touch on any specific protocols and whether you have specific protocols. And then I want to talk about barriers, just thinking about and any roadblocks, rough spots that you've hit, thinking about the 15 minutes we have left. So Esther, you guys have a very different approach than Connors. We actually have the same. We have a critical care cardiologist as the point person who takes in most of the information initial and then makes a decision about whether to activate the shock team. And we did that to reduce the number of false activations because we didn't want to get that broader group on at 2 a.m., at 4 a.m., at 6 a.m. And I wonder, what has your experience been on that front? Do you end up with a lot of false activations, or is your filter good enough that that system of just calling everyone at once works well?
We get some false activations. And so but the way we approach it is we're going to acknowledge that, right? So the hope, kind of the skin in the game is that, yes, you're going to get some false activations, but hopefully we're catching shock earlier. So the cath lab is coming in less at 2 a.m. The cardiac surgeons, they're weird creatures, right? They don't like to sleep and things like that. So they want to have less people on ECMO. They want us to be catching these folks earlier so that they have to do less ECMO. Right. And so in heart failure, we're weird in our own ways, right? We want to be able to, we like to talk about things and ruminate on them. So we get, that itch scratch. So, yes, we absolutely have false activations, or we have activations sometimes from the MICU at 2 a.m. for someone who's cirrhotic with endocarditis. Okay. But we take that as then, man, we get in trouble and we have to call pulmonary. And now we have this a little bit, we help them out. They're going to help us out. And I'll say the last thing about payment for Connor, just, if you're at a transplant or VAD center, this can sometimes come under your Medicare timesheets. So that's the one thing we are working on getting done. So I'll let you know if it's successful.
All right, I'm going to go around the room quickly. So Connor, you described how the critical care cardiologist is the point person. When you have that group call, just practically, how do you reach out to everyone? Does your call center do it? Are you doing it on your iPhone? It's you.
We do it all. Yeah, it's just quick. So we have, like you said, very similar to Esther's system. We have champions, and we find people that for specific things that we just know we can get and we just know because people get weird on data. If you don't have people to say, here's what you're going to know before they come, here are the things we kind of agreed upon to say yes, no, so we're not bringing people unnecessarily. And there's going to be certain unknowns, right? Like TAVR, there's some basics getting in. They're not going to have a gated TAVR CT yet. So we don't so we let that go.
And Karen, how do you guys activate? How do you bring everyone on the line?
Yeah, so mostly going through Joyce, who's our shock team leader, or through Transfer Center, and then they get a hold of Joyce. She hears the two-liner and then decides who to bring into the call.
Wow, that's a lot centralized to one person. Tom, how do you guys do it?
Ours matters whether it's in the hospital or out of the hospital. In the hospital, we have a dedicated phone line that we purchased. And so we will call the pager system and then they'll send out a page. We get everybody in the same phone line. And that worked better than initially we had this sort of clunky, the fellow had to have the phone and had to page everybody in on the iPhone and then people get dropped and it didn't work out well. So we bought a phone line for it. Out of the hospital, we end up doing the same thing, but we start with a transfer center call to just the heart failure cardiologist, or if they are on via ECMO or needing via ECMO to the CT surgeon. And then we activate the shock team after that to discuss the remainder of the case with the parties involved.
Yeah, what we do is actually from the outside, it goes through our call center, and then we can have them, I get it first as the critical care cardiologist, and then I can decide whether we bring the whole shock team on into Esther's point, whether there's anyone else or Karen's as well. If I need OB on or congenital, I can have those folks join. And then in-house, we have it's a virtual group page that brings everyone to a single number. So you can see that there are actually 5 slightly different ways of trying to achieve the same thing. Tom, I noticed that in your algorithm, they're the building blocks of everything that's important in the information that you consider around making an MCS decision, but they're not a lot of like direct lines of if this, then absolutely you do this.
Yeah.
And I would be interested in your perspective on that. And then maybe we'll just go quickly around the group and just get yay or nay to sort of whether you have a strict algorithmic protocol or whether it's more of a little bit of a conceptual framework.
So
Tom,
to
I'll let you
be so
start.
prescriptive in an algorithm, I think unfortunately we are still in a little bit of a black box around data with what exactly we need to do. And so we have experience, but my experience might be slightly different than your experience. I think that what we really want to do is we want to prompt people to think about these elements, but it's very hard to put pen to paper exactly what should be done. And maybe AI will help us do this or something, or maybe more data will help us do this. But I don't know that we're smart enough to say exactly what needs to be done in every situation because there's so many permutations. But I view the shock team. Our earlier discussion, I was going to say this point. I think one of the secret sauces is what we put on the paper. The other is just the spillover effect of having a shock team. It actually changes the culture around shock and makes it the forefront of everyone's mind and makes us really thinking about important elements. And somehow, when you shove that into a system, it leads us to be maybe more aggressive, but in the right ways for patients. So even in our current system, we see all the deficiencies of data that we need to fill in this block and make a more direct line. Right now, we build it to prompt about what we think are the essential elements and then leave it to the multidisciplinary discussion to actually make that decision in real time.
Yeah. I'm going
One
to pivot a
thing,
little bit because of the time and ask the others maybe to start, just give us the top barrier or top pitfall, the area that you want people to be aware of if they're thinking about starting their own system. And then there's a great question in the chat about debriefing. I want to make sure we get to that too. What data do you use? But first, maybe I'll start with you, Karen, if you had to name the sort of number one challenge that you've faced that you want people to think about.
I mean, I think the system we have is working. I think it's very time intensive for our shock leaders. So I think having a better way of having people maybe rotate and taking the triage calls. And then I think there's going to be this element of false alarms. If there was a better way for us to, vet how sick patients are and whether they're truly advanced therapies candidates, because there's always something when the patient arrives, like they don't have a leg or there's some cancer that we missed. And so I don't know, just coming up with a better algorithm or better set of questions to make sure that, we're not bringing folks over that are potentially not candidates for anything.
Yeah, no, I think that's sort of that triage flow and
Yeah.
whether we can build a lot of that up front is a good question that we're grappling with too. We have our call center now go through a longer list before they get to us so that we have that information available. But it's difficult because you also don't want to keep referring docs who are, in the lab or struggling with a patient to have to spend a lot of time on the line. They don't want to do that either. Esther, what's your top challenge that you'd highlight?
My top challenge is I still maintain recognition of shock. That's not building the shock team. That's just the thing in shock.
Yeah.
To me, it is getting continued buy-in when you don't always get protected time, and so it really has to be a joint. It's a little labor of love, and people have to feel like they're getting something out of it. And I'm answering one of the questions in the chat that's going to talk about highlighting successes, right? Like there's a lot of emotions that we, as doctors, we're told not to we didn't used to be told to process. There's a lot of tough things that we see. And so I think like the ability to kind of highlight our successes makes people feel better. Like it's not just highlighting what to improve.
Yeah, no, I think that's absolutely essential. We all work in such high intensity environments, and it's such a high proportion of patients who still don't do well despite our best effort that you really have to highlight and learn from the wins as well as from the potential losses. Connor, what about your number one challenge?
That'd be real quick because I got three things. Just one, we just make ourselves very available to referrings to help do rapid data identification to really fit, like they said, you have an echo, show me your VTI. If it's not traced, I'll run over the screen with you to like just really help understand who you're bringing in and escalate quickly. Two, we developed a rapid transfer unit where it's dedicated neurology and cardiology because its idea is you can land an ICU patient there and they can upgrade or stay ICU or even downgrade or go straight to a procedural suite or get something done immediately. And that you can't admit from anywhere else in the hospital to that space. And that really helps us get those patients in and rapidly triage, and it preserves MCS beds in our CICU. That was tremendous. That really increased our rapidity of transfer. Third, or two more things. We leave all transfers open. A lot of hospitals cancel transfers for capacity, and I found that just when we leave things open, beds come up, and rather than making people call back, you just get because that takes the lift off you, and patient placement just brings them in when there's beds available. That made a big difference. And then fourth, one of our biggest barriers, we do almost all of our procedures bedside. We cannulate ourselves, we do balloon pump, like you name it. It helps us with safety for devices because we've learned how to do all of our hemostasis checks and do most of it ourselves. B, it also just takes the heat off all of the procedural services with overrun cath labs, overrun ORs, and these patients that are really hard to move in and out of those places. We just do it there, and then it really focuses the resources and reduces costs because now you're not using other things, you're using resources that are just already dedicated to that patient. And it also really improves the time to get people on because you don't have all the delays of phone calls and mobilization. So, and then everybody's education level, you just start training other intensivists, and that just expands, just like Thomas said, with all the education you do it, teach the next person, they teach three people, and all of a sudden, boom, everybody knows how to do it.
Yeah, no, those are all fantastic bits of practical advice. We're coming to the close and we will end on time. It just makes me realize how much there is to talk about shock and shock teams. Karen, maybe I'll go to you and just ask, what do you do in terms of data? How do you gather the data to help you work on improving your shock system of care?
Yes, so I think we gathered data more for research. I think we probably should be doing more of the quality improvement, but anytime somebody's coming through as a shock call, their data is being collected into sort of a research database. And many of these patients are then, approached for randomized trials if there's a trial for shock. But I think QI, it's more just us getting together and debriefing and talking about how things could have gone different. I don't think we've formally gone back to the data to do any sort of QI work, but I think it's important.
Yeah, no, and thank you, Esther, for answering so many of the chat questions. You've been knocking those off. Connor didn't respond to the critical care cardiologist, which tells me he wasn't looking.
Oh, I wasn't looking. Let me do that.
You can respond to the chat. And I'll go ahead and close things out and thank all of you for just a terrific conversation. And I'd say as well that I'd be remiss if I didn't make a plug for the AHA Cardiogenic Shock Registry that's hosting this grand rounds. I think it is, we have quite a few built-in dashboards so that you can look at your own data real time when you're participating. And that you're able to bring up metrics on how you're approaching your patients, use of your shock teams, your outcomes, your device utilization, complications, and we're always looking for new ways to build in quality improvement instruments. And for anyone who's not already participating in the registry, you can see the website there and our contact email and easy way to reach out to the team if you're interested. So thank you again to all of our fantastic panelists and to Dr. Hamp for really leading the way. And thank you to our audience. For those of you that still had questions that weren't answered in the chat, I am happy to try and coordinate getting answers to you. So I'll work with the AHA team so that there isn't anything that was left in the chat unanswered. Thank you all and have a wonderful afternoon.